So this is last but one part, and here we are going to begin with the pressure ulcer and some more procedures like the local treatment of the burns and the destruction of the lesion that we will complete. And then the next part will be exclusively Mohs micrographic surgery and then the breast procedure. So let us begin with the pressure ulcer. Pressure ulcer, also known as a decubitus ulcer, plaster ulcer or bed sores, developed in the pressure bearing areas of the body such as elbow, back, hips, sacrum and heels. Now from the CPT coding perspective, treatment codes are selected based on how the ulcers are treated. Debridement of the pressure ulcer, where it involves the removal of the necrotic or diseased tissue to expose healthy red tissue. The depth and the extent of the debridement determines the correct CPT code, and we have already seen the debridement code. If it's a superficial debridement, then we code from the 90,000 series, which is covered in the medicine section, where we only do the superficial layer removal. And if it is a deeper debridement, we have already seen the code from 11042 series, where we debride the ulcer till the subcutaneous tissue, muscle and the fascia. So this is the debridement code. There is one more way we can treat the pressure ulcer is by the excision of the pressure ulcer. Excision is different from debridement because it involves the complete removal of the ulcer rather than just cleaning out the dead tissue. This procedure typically involves elliptical removal of the ulcer, cleaning out the entire affected area. CPT code for the excision depend on the various methods, that is primary closure, closure with skin flap and myocutaneous flap, or closure with a osteotomy. Accurate documentation and the correct CPT code selection are crucial for proper medical coding, billing and reimbursement. Now here I have tried to given the various ulcer. One is a sacral ulcer, which is located at the base of the spine just above the tailbone and occurs in the patient who spend prolonged time lying on their back. Then there is a ischial ulcer. It is lower part of the pelvis forming the base of the buttock. Usually the patient who are in the wheelchair bound, you will see them. And the then trochanteric ulcer. These are basically referred to as a greater in the region where there is a greater trochanter, and it is basically in a patient who frequently lie on their side for the extended period, that is the outer side of the hip. So this is just information for you, so that sometimes they do ask in the anatomy that where do you find the location of the ischial or the trochanteric ulcer, so you should know that. So these are the code for the ulcer 15922, and the code begin with 920 to 15999. It always help, and these codes are for the excision, because if you see everywhere it is written excision. Now I'm just going to highlight the word because this is the excision of which sacral pressure ulcer. Then you have the code for the excision of the ischial pressure ulcer, and then you have the code for the trochanteric ulcer. Now everywhere they have given how you have done the excision. Is it excision followed by the primary suture, or with the osteotomy, or with the skin flap closure? So that is very important, and there are various parenthetical note which are written. So if you see the code 15937, there is a clear cut note that for the repair of the defect using the muscle and myocutaneous flap, we have to use the code 734 and 738 in addition to 936 and 937. So there are various important information which are written. Now you should know what is osteotomy means. Osteotomy means sometime whenever the ulcer is very deep and it has gone till the bone, sometime, and when we are trying to do the excision, we will take out that infected bone also, and for that we will do the osteotomy. So pay attention whether it is a deep ulcer where it has gone till the bone, and whether they have taken down the bone also, because when they have taken down the bone, then we will have to write the code which talks about the osteotomy. So these are all important words as far as the codes for the excision of the pressure ulcer is concerned. This is the treatment where we are trying to excise the pressure ulcer. So very important word. Now let us see how this guideline was tested. This 37-year-old paraplegic has developed a sacral decubitus ulcer. He is brought to OR today for the debridement of the pressure ulcer with the split thickness graft to cover the defect. The patient was placed prone on the operative table. After induction of the adequate endotracheal anesthesia, the sacral area was prepped, draped in a sterile fashion, and the ulcer was inspected. The area is debrided extensively to the healthy tissue, involved bone, including the part of the cockage, and it was also removed. Once the area was clear of necrotic tissue, the site was prepped for the skin graft. The split thickness skin graft was harvested from the thigh with a dermatome. Total graft size was 25 square centimeter. The graft was sutured in a place using 60 Vicryl. The harvest site was closed primarily with the skin staple. Dressing were applied. Needle count were correct to 2. The patient tolerated the procedure. Code the procedure. And now let us see what are our options. The first option is 15002 and 15100. This is the surgical preparation. Here the surgical preparation didn't happen, but they have done the excision of the ulcer. So 15002 will not be the right code, and it is followed by 15100, which is a split thickness graft. Definitely the split thickness graft is the important code that we are going to use it. But let us see the code 15937, and it is the code for the excision. Now this is the indented code. So what I will do, excision of the sacral pressure ulcer in preparation of the muscle and myocutaneous flap or the skin graft closure with osteotomy. What does give me the impression that osteotomy happened? Because they have removed, including the part of the cockage, which is a vertebra, was also removed. So the bone is removed and the cut as happened. So we will require a code 15937 with the osteotomy. And below the osteotomy, below the 15937, there is a the parenthetical note. Kindly read that note. It says that if the split thickness graft has happened, then we will have to use the code 15100. So pick up the code 15100, split thickness autograft tongue, arm and legs. Where did it happen? In this case, it is a sacral ulcer. Okay, where is the sacral ulcer? At the back. I just taught you that, and that's why we will require this code 15100. That is a very important code that we will require, and we will take that code, and it is covering how much area? First 100 square centimeter. What is our area? Is 25 square centimeter. So we will require this code. So remember, this code 15937, it only talks about osteotomy, but it does not talks about the split thickness, and we are coding for the whole procedure. So we will require both the codes. So let us see what's the answer. So the our answer will be answer B, that is 15937 and 15100. And here I have given the explanation for the rationale for the answer. And if you see the code 15937, below that also there is a note that for repair of the defect using the flap we have to use this code, but here it is a graft, and for the graft repair of the defect using the split thickness graft, use the code 15100 15101 in addition to. So whenever I am writing this code, I will have to write this code if the split thickness graft is done, and this is an additional procedure, so we will put a modifier 51 here. Now the next topic is burns local treatment. Now what is a local treatment? See, whenever the burns happen, depending upon how the burns are, whether it is a superficial burn, stage 2 or stage 3 burn, depending upon we give the treatment. So here we are going to talk about the treatment where the burns are very superficial and it requires only the local treatment. So let's see. So burn local treatment code are from 16000 to 16036, and it is mainly for the local treatment of the burn surface, and all these words are very important. This code to be used when no graft and flap is required and a local dressing can be done. So this is basically for the first degree burn, and it could be for the slightly deeper burn, but the treatment is local. And here you pay attention to all the word initial treatment and what is the area that is involved, that we have to write here. So let us go with the example for this so that you will understand and pay attention to all the parenthetical notes. So let us take the example: a 30-year-old male patient who sustained a second degree burn to his entire back in the house fire will had a daily dressing change and a debridement for the first 5 days. This procedure is painful and required anesthesia. The following 5 days, the dead tissue was incised from the area each day. Which of the following answer best describe his encounter? Now we need to underline the area. What is it? It is a sustaining second degree burn. And then what has happened is the debridement happened for the first 5 days. Okay. This is very, very important. And then the procedure was painful. The following 5 days, that is the next 5 days, the dead tissue was incised from the area each day. So these are the important thing, and now we need to put that into things, into our answer. So this is a second degree burn. Then the first 5 days the debridement happened, and then the second following 5 days the dead tissue was incised. Now that is called as a eschar. Remember that these are the important medical terminology you must know. And now we will zero down our answer. Now, by studying the option, we will, eliminate the wrong option. The first is 16000 because this is a different code. So it talks about the initial treatment of the first degree burn. What is our burn? It is a second degree burn. So that means it is a partial thickness burn. So we will require a code 16020, but it talks about the dressing and debridement of the partial thickness burn, initial or subsequent small area. What is our area? Our area is entire back. And if you remember in the ICD, we always have a rule of 9. The trunk is 18%, and because of that we will require the larger area, and that is because it is greater than 10%. What is full trunk is what they have said, and in this case we will require, so we will require a code 16030. So definitely A, B, C. Now we need to check the second code 16035. It is for the hysterectomy. Did the hysterectomy happen? Yes, because the following 5 days, because 16030 it covers the first 5 days. Now 16035 it is the following 5 day. It is a hysterectomy initial incision, and then there is a add-on code. Each additional incision we separately in addition to the code for the primary procedure, and here it is written 16036 in conjunction with 16035, and for the debridement curate of the burn wound see 16020. So the debridement and curettage that happened, that we have covered, and now the dead tissue removal, for that we will require a code 16035, but it is a first day incision, and following every day you will have to take the new incision, and for that we will require 16035. Now why this is not the correct code? Because this is 16035 into 4 is not the correct. 16035 it talks about only for the initial incision, but the remaining 4 incision it doesn't cover. So the C answer is the correct answer, because it talks about 16035 and 16036 into 5 each additional incision, and that we will require, and that's why the correct answer will be answer C, and we will write that answer. So let us take the example. James suffered a severe crushing injury to his left leg. 2 days after the surgery, Dr. Barnes completed a dressing change under general anesthesia. How would you report this service? So let us eliminate the wrong answer. 16020, it is a dressing and a debridement for the partial thickness, initial and subsequent small, and this is a burn treatment. So I will not require this code. Let us see what is this code. Dressing change under anesthesia other than local. And this is what has happened in our case. It is a severe crushing injury to his left leg and the dressing change under general anesthesia. And if you see here, it is written for other than burns. So definitely it is the code that I will require, 15852. So automatically it will eliminate the option C also. Now in between B and D, if you see the code 15852, it includes the anesthesia. So that means the language is there under the anesthesia. So I cannot take 01232, and this is the code for the anesthetist, and we are coding for the surgeon. So and the code includes anesthesia. So 15852 is the correct code, and LT is the modifier that I'll be using. So D is the correct answer, and here I have given the rationale. Kindly go through it. Now the next topic is destruction. What is a destruction? Destruction refers to as a complete removal or eradication of an abnormal tissue growth using various methods like cryotherapy, electrosurgery, laser surgery, chemical treatment, with a goal of eliminating the abnormal tissue without necessarily requiring the closure of the area afterwards. Often used for the benign precancerous skin lesion like warts, actinic keratosis, or skin tags. Now the key method for the lesion are cryotherapy, where we use the extreme cold, electrosurgery, where we are using the electric current or the hot source to destroy the lesion. Laser is basically focus beam of light to target and destroy the lesion. Chemical destruction is by applying the chemical agent which are corrosive and to destroy the lesion, and curate is scrapping. Now, important factor in considering the destruction code is basically the type of the lesion required, and then the treatment that is required. Now let us study the guideline for the destruction. In this case, one must identify what is the type of the lesion, whether it is benign, pre-malignant, or the malignant. Then one must identify the type of the technique, whether it is cryo, chemo, laser, or electrical. But important note is that the technique is irrelevant because most of the code includes all the technique, and there is no separate code if the technique is different. Like for the cryo, chemo, and laser, the code which we are going to use is the same. So the technique is does not matter that much, and the benign and pre-malignant lesion are not based on the site, anatomical site, but based on the number of the lesion. So we count the number of the lesion as far as the benign and pre-malignant is concerned. And of course, we know that when to use the add-on code and when to use the 51. We never use a 51 modifier on the add-on code. And as far as the malignant lesion destruction is concerned, they are based on the anatomical site, and we do have an anatomical grouping. And we see the diameter of the lesion, and we do not add the diameter of the lesion. This is a very important code. We code each lesion separately, and if the doctor has destroyed the malignant and the benign lesion in one sitting, or the pre-malignant lesion in one sitting, then the hierarchy is we always code the malignant first, followed by the benign or pre-malignant. Now, what is a pre-malignant lesion? These are the abnormal cells which are associated with an increased risk of developing into the cancer. And actinic keratosis is a very important pre-malignant lesion. Sometime in anatomy section, they do ask what is a pre-malignant lesion. So this is the definition. An example is actinic keratosis. And these are the various way we can destroy the various lesions. So these are the code for the destruction, and I want your complete attention here that these are the code 17000 till 17108. These are the code for the destruction of the pre-malignant lesion, and I can very well clearly see here the pre-malignant lesion. These are the code for the destruction of the benign lesion. Here it is very clearly given, and these are the code for the destruction of the malignant lesion. So first have a look at all the codes. Now we will go into the detail. So these are the code for the destruction of the pre-malignant lesion, and I want you to have a complete attention here. Destruction is there, and then here they have written the pre-malignant lesion. But remember, this is the primary code and it covers only the first lesion. And then 17003 is the add-on code and it covers second through 14 lesion, and it is written each. So remember that use 17003 in conjunction with 17000, and for the destruction of the common or the plantar warts, which is a benign lesion, they have told us to code them from 17110 to 17111. And here this is the third code 17004, and it talks about the destruction for more pre-malignant lesion again, but 15 or more lesions. So this is very, very important, these three codes, because sometimes the student may get confused. Now let us take the example. The word each in the description, the word in the description indicates that you bill with a unit for each additional lesion. Now the dermatologist destroy 7 actinic keratosis, and how would you report the following? Actinic keratosis means the pre-malignant lesion. That means I will come directly here. Now in this case you will have to code them. How will you code it? So how many lesions are there? 7. So I will code 17000 for the first lesion, and then 17003 into 6 for the remaining 6 lesion. Okay, remember that. A patient undergoes for the destruction of the pre-malignant lesion. The patient had 6 lesions. What are the correct code for this services? So I will code 17000 and 17003 into 5, because we are coding for how many? 6 lesion. So the first lesion 17000 and 17005 is for the additional remaining 5 lesions. Now let us take this example. What CPT codes are reported for the destruction of the 16 pre-malignant lesion and 10 benign lesion other than the skin tags using cryosurgery? So for the 16 pre-malignant lesion, we can directly code 17004, because the code language says that you can use this code for 15 or more lesion, and I will require only one code because it include. So if there are 22 lesions also, I will only code 17004 only once. That is very, very important, and that covers the 16 pre-malignant lesion. And for the 10 benign lesion other than the skin tags, we are going to code 17110. And destruction of the benign lesion other than the skin tags or cutaneous vascular proliferative lesion up to 14 hours is 10 lesion. And in this also we will code pre-malignant first followed by benign, because the hierarchy is always malignant, pre-malignant and benign. So let us take one more example. The patient is diagnosed with a superficial basal cell carcinoma of the neck and cheek. After discussing with the physician about a different treatment option, the patient decided to have this lesion destroyed using cryosurgery. Using cryosurgery, the physician destroyed the lesion on the neck measuring 2.3 centimeter and a lesion on the cheek measuring 0.8 centimeter. So let us see what we have. So first of all, this is a basal cell carcinoma. That means it is a malignant lesion. So we can directly come to the malignant lesion, and it is destruction. The method is we also know. And we need to find out the lesion. The neck lesion is 2.3 centimeter and the cheek lesion is 0.8 centimeter. Remember, in the malignant we count the number of the lesion and we do not add the diameter. So here it is a destruction of the malignant lesion, and first is of the neck. So the neck, we have the body, different body group here. So the neck is here, and the second is cheek, which is a part of the face. So we can see the face also. This is a two different group. And so for the first, neck is 2.3 centimeter. So I will require the code 17273, because here it covers that lesion diameter. And the second code is on the cheek, and diameter is 0.8. So I will require the code 17281. So I'm going to write this two code, and I will require a 59 modifier to tell that these were two different lesions. Let us take one example which is based on this guideline. A 50-year-old female has a telangiectasias of the face on both the cheeks. She is very bothered and bothered by this and present to have them destroyed via laser. The physician laser one cutaneous vascular lesion on each cheek. Each lesion measured 2 square centimeter. What CPT code are reported? And we have given option. So let us eliminate the wrong option and then we can find out our answer. So by looking at the code 17263 is a malignant lesion. This is definitely not a malignant lesion. 1700 and 17003 is one. This is a pre-malignant lesion. So we cannot have that. 17110, it is other than the skin tag and a cutaneous vascular proliferative lesion, and this is the cutaneous vascular, so I can't even take 17110. And 17106 is the destruction of the cutaneous vascular proliferation lesion, and then the lesion diameter is less than 10 square centimeter. In our case, it is each lesion measuring 2 square centimeter, and there were two lesions on both the cheeks, so overall diameter become 4 square centimeter, and that's why our answer will be 17106. And this way we conclude all the topics. There are few more topics which are remaining, that is Mohs micrographic surgery and the biopsies and related procedure on the breast, but that we will cover in the part 6 of integumentary system.